Dr. Elena Martinez adjusted the torn jacket she'd borrowed from the theater department's costume collection. The authenticity made her uncomfortable. The frayed cuffs, the permanent stains, the smell of donated clothing that had seen too many lives. She caught her reflection in the glass doors of St. Catherine's Medical Center and almost didn't recognize herself. 48 years old. 2 decades as a trauma surgeon. Chief of surgery at Memorial Hospital across town. Member of St. Catherine's Hospital Board of Directors for 6 years. And tonight, she looked like every stereotype people tried not to stare at on the street. Her administrative assistant had protested this plan for 3 weeks. Dr. Martinez, this is dangerous. What if there's a real emergency? What if someone recognizes you? But Elena had spent 6 months reviewing the complaints. 15 formal grievances in 18 months, all from patients who appeared indigent or homeless. Complaints of dismissive care, long wait times, inadequate pain management, and what one patient described as being treated like I wasn't human. The hospital administration had investigated each complaint individually, finding no evidence of systemic bias and chalking incidents up to misunderstandings or personality conflicts. But Elena had recognized a pattern that those investigations deliberately refused to see. So she'd approved a quality assessment audit, of herself, essentially. Only the hospital's CEO knew the truth. Elena would present as an unhoused patient with a minor complaint. She'd observe triage protocols, wait times, and staff interactions. Document everything. The hospital's own board policy mandated her authority to conduct assessments by any means necessary to ensure patient care standards. The automatic doors whooshed open. The ER waiting room held about 30 people in various states of distress. A young mother with a feverish toddler. 2 construction workers, one clutching a bloodied hand. An elderly man with labored breathing. A teenage girl bent over her phone while her friend held an ice pack to her ankle. And in the corner, 2 security guards stood talking, their attention frequently scanning the room with the practiced vigilance of people paid to identify threats. Elena approached the triage window. The nurse behind the plexiglass was scrolling through her phone, half attention on the computer screen showing wait times. "Excuse me," Elena said quietly. The nurse looked up. Her expression shifted almost imperceptibly, a micro-expression that Elena had learned to read in her years of surgery. Wariness replacing neutral professionalism. "Yes." The nurse's hand moved to the hand sanitizer bottle. Subconscious. Or deliberate signal. "I need to see a doctor. I've got this cough that won't go away, and my chest hurts when I breathe deep." The nurse's eyes traveled over Elena's appearance. The torn jacket. The worn shoes. The reusable grocery bag that held Elena's actual belongings. Her real ID. Her hospital credentials. Her phone recording everything through a small hole in the fabric. "How long have you had these symptoms?" "About 3 weeks. And you're just coming in now?" The question had an edge that wouldn't have been there if Elena wore her usual professional attire. She'd done this experiment before in her mind, wargaming the responses. Now she was living it. "I was hoping it would get better on its own." The nurse typed something into her computer. "Insurance. I don't have insurance right now." More typing. "ID." Elena handed over the temporary identification she'd obtained. Her real name, but listing a shelter as her address. Everything technically true. Everything legal. Everything documented. The nurse examined it like it might be counterfeit. "Have you been here before?" "No." "Any drug allergies we should know about?" The question was standard protocol. But Elena noticed the emphasis on drug, the way the nurse's eyes narrowed slightly. "Penicillin," Elena answered truthfully. "Anything else?" "No." The nurse printed a wristband and slid it under the plexiglass along with a clipboard. "Fill out these forms. We'll call you when it's your turn. Probably be about 3 to 4 hours." Elena glanced at the digital board showing current wait times. Most patients were being seen within 4 to 5 minutes to an hour. But she said nothing, just took the forms to the waiting area. She chose a seat with a view of the entire room and settled in to observe. The teenage girl with the sprained ankle was called within 20 minutes. The mother with the feverish toddler within 30. Elena watched the construction worker with the hand injury go back after 40 minutes. She'd been waiting an hour when a man in his 50s entered the ER. His clothes were dirty but not torn. He had the weathered look of someone who spent most of his time outside. He approached the triage window. Elena watched the interaction carefully. The same nurse, her name tag read Jennifer Morrison, RN, looked up. Need help? Not how can I help you? Elena noticed the subtle difference in phrasing. I fell earlier. My back is really hurting and I can't put weight on my right leg. How did you fall? Tripped on the sidewalk near the shelter. Jennifer's expression closed off slightly. Have you been drinking? No. I just tripped. The sidewalk's all broken up there. MMHMM. Jennifer typed. ID. The man produced a worn driver's license. Jennifer examined it with the same skepticism she'd shown Elena's ID. Insurance. No. Fill out these forms. We'll call you. The man took the forms and sat down, moving carefully. Elena noticed how he winced when he sat, how he kept shifting trying to find a position that didn't hurt. 90 minutes passed. Elena watched the pattern repeat. Well-dressed patients moved through quickly. Patients who appeared to have resources got faster service. The man who'd fallen still waited, his face tight with pain. At 2 hours and 15 minutes, Elena approached the triage window again. Jennifer looked up with visible irritation. Yes. I'm sorry to bother you, but I've been waiting over 2 hours. My chest pain is getting worse. Jennifer didn't look at her computer. We're very busy tonight. You'll be called when it's your turn. I understand, but I'm having trouble breathing, Anne. If you were having a medical emergency, we'd see you immediately. As you can see, there are many patients ahead of you. Elena glanced at the waiting room. It was actually less crowded than when she'd arrived. Several people who'd come in after her had already been seen. Could you at least check my vitals? My chest really. Jennifer held up a hand. I need you to return to your seat. We will call you when we're ready. If you continue to interrupt, I'll have to ask security to speak with you. The two security guards had noticed the interaction. They were watching now, their body language shifting to alert readiness. Elena returned to her seat. Her phone, still recording from inside her bag, had captured everything. A young woman in scrubs, a medical student based on the short white coat and identification badge, sat down nearby during her break. She'd been watching the interactions at triage with increasing discomfort. That's not right, she muttered, more to herself than anyone else. Elena glanced at her. What's not right? The medical student seemed to realize she'd spoken aloud. She hesitated, looking around to see who might overhear. Nothing. Never mind. It's okay, Elena said gently. You can say it. The student lowered her voice. I've been watching. People who look like they have money are getting seen faster. It shouldn't work like that. No, Elena agreed. It shouldn't. I'm just a med student, the woman said, her name tag identifying her as Sarah Chen, MS3. I can't really do anything about it. But I see it. We all see it. Elena wanted to tell her that seeing it and naming it was the first step. That speaking up, even as a student, mattered. But she maintained her role. Have you seen this before? Elena asked. Sarah nodded, then seemed to catch herself. I should get back. She stood, then paused. For what it's worth, I hope they see you soon. And I hope that cough gets better. Thank you. After Sarah left, Elena noticed one of the security guards had moved closer. He was a large man, mid-30s, with the kind of build that suggested he was paid primarily for physical presence. His name tag read Marcus Williams, Security. He stood near Elena's chair, not quite looking at her but making his proximity obvious. Elena pulled out a small notebook, actually part of her documentation process, and began making notes. Marcus shifted position to see what she was writing. What are you writing? Elena looked up calmly. Personal notes. About what? My symptoms. When they started, how they've progressed. I thought it might help the doctor when I'm finally seen. It was a perfectly reasonable explanation. Marcus seemed unsure how to respond. Just asking, he said finally, moving back to his post. But Elena had noticed how the question was phrased. Not concerned about her welfare. Suspicious about her motives. As if documenting her own medical history was somehow threatening. At 3 hours, the man who'd fallen was finally called. He stood carefully, pain evident in every movement. As he passed Elena, their eyes met briefly. His expression held exhaustion and resignation. Someone used to being made to wait, used to being treated as less than. 20 minutes later, he emerged from the back. Elena noticed he was still moving with difficulty, but now he carried a single piece of paper. What did they say? Elena asked as he passed. He paused, surprised to be addressed. Said nothing's broken. Gave me these exercises to do and told me to take ibuprofen. Did they do any imaging? X-rays? Nope. Doctor said if it's not better in a week, come back. He shuffled toward the exit, still limping, still in obvious pain. Elena made a note. No imaging for a full patient reporting inability to bear weight. That alone was a violation of standard care protocols. At 3 hours and 45 minutes, her name was finally called. Elena Martinez. She gathered her bag and followed the nurse, different from Jennifer, through the doors to the treatment area. The nurse, whose tag read Robert Chen, RN, pointed to a room. Bed 3. Get changed into this gown. Doctor will be with you shortly. The examination room was small, with a rolling stool, a narrow bed, a blood pressure cuff, and the standard medical equipment. Elena changed into the gown, maintaining her documentation. Her phone now sat in the pocket of her discarded jacket, still recording. 15 minutes passed. Then 20. She could hear activity in the hallway, nurses talking, the beep of monitors, the sound of a crash cat being rolled past quickly. Finally, a doctor entered. Young, maybe early 30s. His name tag identified him as Dr. Michael Stevens, emergency medicine resident. He didn't make eye contact, just looked at the chart on his tablet. Says here you have a cough and chest pain. How long? About 3 weeks. Any fever? No, but. Shortness of breath? Yes, when I. Coughing up blood? No, but. Dr. Stevens cut her off with each question, moving through his checklist mechanically. He still hadn't looked at her face. Have you been exposed to anyone sick? I don't think so. I wanted to mention that. Any recent travel? No, I. Okay, let me listen to your lungs. He finally approached, placing his stethoscope against her back through the gown. Breathe in. Breathe out. Again. He listened for maybe 15 seconds total. Nowhere near the thorough lung examination Elena would have conducted on a patient presenting with these symptoms. Sounds clear. Probably just a viral infection. It should resolve on its own. Doctor, I'm concerned that. I'll write you a prescription for a cough suppressant. Take it at night so you can sleep. Drink plenty of fluids. If you're not better in 2 weeks, follow up with a primary care physician. I don't have a primary. There are community clinics. Check with social services on your way out. He was already moving toward the door, typing notes into his tablet. Wait, Elena said, her voice firmer now. I have a history of cardiac issues in my family. My father died of a heart attack at 52. I'm concerned this chest pain might be. Dr. Stevens finally paused. Have you had any cardiac symptoms? Radiating pain down your arm. Jaw pain. Sweating. Some sweating. Yes, Anne. That's probably just from the cough. Your age and. He gestured vaguely at her appearance. Lifestyle don't really fit the profile for cardiac issues. Elena felt her professional mask slip for just a moment. My lifestyle. Well, Dr. Stevens said carefully, cardiac disease is typically associated with different risk factors. I think we're looking at a simple respiratory infection. Nothing to worry about. I would feel more comfortable if we could do an EKG or... We need to reserve those resources for patients with actual cardiac symptoms. I understand you're concerned, but this is really just a cold that's hanging on. Give it another week or 2. He left before she could respond. Elena sat alone in the examination room, processing what had just happened. In her 20 years as a surgeon, she'd never conducted such a cursory examination. She'd never dismissed a patient's concerns so completely. She'd never made assumptions about someone's health risks based on their appearance. But she'd just watched it happen to her. Robert, the nurse, returned with discharge papers. "Sign here. You can get dressed. Your prescription will be sent to the pharmacy in the lobby. I'd like to speak with the attending physician. Dr. Stevens is supervised by Dr. Patel, but she's dealing with a trauma case right now. Then I'll wait." Robert's expression shifted to annoyance. "You've been discharged. You need to leave so we can see other patients. I'm not satisfied with the level of care I received. You're welcome to file a complaint with patient services, but you need to leave this room now." Elena stood, maintaining her dignity. "I'm a patient who presented with chest pain and shortness of breath. I was given a 5-minute examination and discharged without any diagnostic testing. That's not acceptable care. You're in an emergency room. We treat emergencies. You don't have an emergency. How would you know if no one did any actual diagnostics?" Robert's hand moved to the phone on the wall. "I'm going to call security if you don't leave voluntarily." Elena gathered her belongings. As she dressed, she noticed her hands were shaking slightly. Not from fear. From anger at the systematic failure she'd just experienced. In the hallway, she passed Jennifer from triage. The nurse's eyes skated over her dismissively, already looking past her to the next patient. Sarah Chen, the medical student, was at a computer station. Her eyes met Elena's briefly, and Elena saw recognition there, not of who Elena was, but of what had just happened. Marcus, the security guard, positioned himself near the exit as Elena passed, making sure the problem patient actually left. Elena pushed through the automatic doors into the cool night air. 4 hours and 17 minutes. A cursory examination. A dismissive diagnosis. No testing. No thorough assessment. She walked to her car, parked 2 blocks away where no one from the hospital would recognize it. Only when she was safely inside did she allow herself to process the full weight of what she'd experienced. And she'd experienced the good version. She was educated. Articulate. She knew medical terminology. She understood patient rights. She had the confidence to push back, even in character. How much worse was it for patients who didn't have those advantages? Elena pulled out her phone, her real one, and called the hospital CEO. "Martin, it's Elena. I'm done with the assessment. We need to convene an emergency board meeting. Tomorrow." "That bad?" "Worse than the complaints suggested. I documented everything. And Martin, we're not handling this quietly." She ended the call and sat in her car for a moment, watching the ER entrance, watching patients go in, watching people come out, wondering how many were being seen clearly and how many were only being seen through the distorting lens of bias. Tomorrow, things were going to change at St. Catherine's Medical Center, whether they wanted to change or not. Elena arrived at her actual hospital, Memorial, at 6 a.m. She'd been up most of the night reviewing the recordings, transcribing conversations, cross-referencing her experience with the formal complaints filed over the past 18 months. The pattern was undeniable. Her office overlooked the surgical wing. 20 years of her life in this building. She'd helped develop the trauma protocols. She'd trained dozens of residents. She'd served on every major committee. And she'd pushed relentlessly for equitable care standards across all patient populations. But clearly, good intentions and policy documents weren't enough. Her phone buzzed. A text from Martin Reeves, CEO of St. Catherine's. Board meeting set for 2 p.m. Conference room A. I've alerted legal. Elena responded. Good. Also notify PR. This is going to be public. 3 dots appeared, then disappeared. Then, are you sure that's necessary? Elena's fingers moved quickly. I spent 4.5 hours being dismissed, undertreated, and surveilled. That's after complaints from 15 other patients describing identical experiences. The medical board requires transparency. This is necessary. Understood. At 8 a.m., Elena met with her own hospital's patient advocacy team. She'd asked them to research healthcare discrimination data for context. Sarah Winters, Memorial's chief patient advocate, laid out printed reports across the conference table. The data was damning. According to the National Academy of Medicine, Sarah began, patients who appear to be experiencing homelessness wait an average of 3.2 hours longer in ERs than housed patients with identical complaints. They are significantly less likely to receive diagnostic imaging, adequate pain management, or appropriate follow-up care. Elena nodded. What about cardiac symptoms specifically? Sarah pulled up another study on her laptop. When Black patients and Latino patients present with chest pain, they are 30% less likely to receive EKGs compared to white patients with identical symptoms. When patients appear indigent, that disparity increases to 60%. And what are the medical implications of missing cardiac events? Catastrophic. Every hour of delay in treating heart attacks increases mortality by 7.5%. Women and minorities already face higher cardiac mortality because their symptoms are more likely to be dismissed as anxiety or indigestion. Elena thought about Dr. Stevens' quick dismissal. His assumption that her lifestyle meant she wasn't at cardiac risk. What if her chest pain had been real? What if she'd been experiencing an actual cardiac event? I want this compiled into a presentation for the board meeting, Elena said. National data, local data if we can get it. I want them to understand we're not talking about customer service issues. We're talking about life and death disparities. At noon, Elena's assistant knocked on her office door. Dr. Martinez. Dr. Patel from St. Catherine's is here. She says it's urgent. Dr. Anjali Patel entered, looking stressed. She was the attending physician who'd been supervising Dr. Stevens last night, though Elena hadn't actually seen her during the ER visit. Dr. Martinez, I heard about the board meeting. I wanted to speak with you before. Sit down, Anjali. Dr. Patel sat, clasping her hands in her lap. I didn't know you were the patient. Stevens didn't mention, but that's not an excuse. I should have been more present. I should have been reviewing his cases more carefully. Tell me about your standard protocols for chest pain. Anjali recited them precisely. All patients presenting with chest pain receive a thorough history, physical examination including complete lung and cardiac auscultation, EKG, and troponin levels at minimum. Depending on risk factors and presentation, we may also order chest X-ray, CT, or other imaging. And did I receive any of those things? No. Anjali's voice was quiet. Why not? I don't know. Stevens said you were discharged, but I was managing a trauma patient and I didn't review your case until this morning when Martin called me. Look at me, Anjali. Dr. Patel raised her eyes. I'm going to ask you a question, Elena said, and I need you to answer honestly. When you reviewed my case this morning and saw the patient was listed as homeless, did you initially think the care was probably adequate? The silence stretched. Anjali swallowed hard. Yes, I thought it was probably adequate. Until I saw your name. Why? Because Anjali's voice dropped to a whisper. Because I've developed assumptions. About what different patients need. About who's going to follow up with care and who isn't. About who's exaggerating symptoms and who's being truthful. Say it clearly. I've developed biases that affect my medical judgment. Tears formed in Anjali's eyes. Oh God, I've been doing this. Not just Stevens. Meh. Elena's voice softened slightly. You're not alone in this. That's what makes it systemic. But Anjali, people are dying because of these biases. When you dismiss chest pain in a 48-year-old woman, you might be missing the heart attack that kills her. When you do a cursory exam on someone who looks homeless, you might miss the pneumonia, the sepsis, the DVT. What do? You show up to the board meeting. You tell them what you just told me. You advocate for systematic change. And then you help me fix this. After Anjali left, Elena reviewed the video footage one more time. She'd captured everything. Jennifer's expressions at triage, Marcus the security guard's surveillance, Dr. Stevens' dismissive examination. But she'd also captured something else. Sarah Chen, the medical student, watching with visible discomfort. A nurse named Maria who'd paused outside Elena's room, seeming like she wanted to intervene but didn't. A janitor who'd made eye contact with Elena in the waiting room, his expression holding solidarity, someone who recognized shared experience. Systems changed when people became uncomfortable with complicity, when witnesses couldn't unsee what they'd been trained to overlook. Elena's phone rang. The number showed St. Catherine's Hospital Board Chair, Patricia Hamilton. "Elena, Martin briefed me on what happened. I want to apologize personally." "Patricia, I don't need personal apologies. I need institutional change." "Of course. That's why I'm calling. I want to make sure we approach this correctly. Perhaps we could handle this internally. Launch a thorough investigation, implement new training protocols, review our procedures. All of that will happen, but it's not going to happen quietly. Elena, think about the hospital's reputation. Think about how this could affect patient confidence. If word gets out that St. Catherine's has been providing discriminatory care, then patients who've been receiving that discriminatory care will finally have validation. Patients who've been dismissed will know they weren't imagining it. And patients who are currently avoiding medical care because they don't trust hospitals will see that we're serious about change. But the legal exposure is already substantial based on the 15 formal complaints we've received. Patricia, those complaints detailed the exact experiences I had last night. We knew about this. We investigated and found no systemic issues. We were wrong. And now we have a board member's direct documentation that we were wrong." Patricia was silent for a moment. "What exactly are you proposing?" "Full transparency. Public announcement of the assessment results. Acknowledgement of systemic failures. Concrete action plan with measurable outcomes. Independent oversight. And compensation for patients who filed complaints and were dismissed. That's quite a lot. It's the minimum required for actual accountability." At 2 p.m., Elena walked into Conference Room A at St. Catherine's Medical Center. The board of directors was assembled, 12 members including Patricia Hamilton. Martin Reeves, the CEO, sat at one end of the table. The hospital's legal counsel, James Park, sat near him with a thick folder of documents. Also present, Dr. Anjali Patel, Jennifer Morrison from Triage, Dr. Michael Stevens, and Robert Chen, the discharge nurse. They sat separately, looking uncomfortable. Elena had requested one additional attendee, Sarah Chen, the medical student who'd witnessed the interactions in the waiting room. "Thank you all for coming on short notice," Patricia began. "Dr. Martinez has completed an assessment of our emergency department's procedures." Elena stood, connecting her laptop to the room's display system. The screen filled with her presentation title, Systemic Healthcare Discrimination at St. Catherine's Medical Center, Assessment Findings and Required Interventions. She clicked to the first slide, which showed a photograph of herself from last night, torn jacket, worn shoes, grocery bag. The transformation was startling. "Last night, I spent 4.5 hours as a patient in our emergency department. I presented with chest pain, shortness of breath, and a persistent cough, symptoms that should trigger comprehensive cardiac and respiratory assessment. This is what I received instead." She played the video footage. The board watched in silence. Jennifer Morrison's dismissive response at triage. The 3-hour wait. Marcus the security guard's surveillance. Dr. Stevens' 5-minute examination. The discharge without any diagnostic testing. When it ended, the room was silent. "For context," Elena continued, "I've spent 20 years as a trauma surgeon. I'm currently chief of surgery at Memorial Hospital. I have extensive experience with cardiac and respiratory emergencies, and I was told my symptoms were probably just a cold." She clicked to the next slide, showing the 15 formal complaints from the past 18 months. Every one of these patients described experiences identical to mine. Long waits, dismissive care, inadequate examination, premature discharge. And in every case, our internal investigation found no evidence of systemic bias. Board member Thomas Chen, no relation to the other Chens, despite the common surname, raised his hand. Dr. Martinez, how do we know these aren't isolated incidents? Emergency departments are high-stress environments. Mistakes happen. Excellent question. Elena clicked to a new slide showing data compiled by Sarah Winters. According to national research, patients perceived as homeless or indigent wait an average of 3.2 hours longer than other patients with identical complaints. Last night, I waited nearly 4 hours while other patients who arrived after me were seen within 4 to 5 minutes. Another click. Patients who appear indigent are 60% less likely to receive appropriate cardiac workup when presenting with chest pain. I received 0 cardiac assessment despite reporting chest pain, shortness of breath, and family cardiac history. She looked directly at Dr. Stevens. Doctor, what did you say when I asked about cardiac assessment? Stevens shifted uncomfortably. I said your lifestyle didn't fit the profile for cardiac issues. What did you mean by lifestyle? Silence. Please answer the question, Dr. Stevens. The board needs to understand the assumptions being made about patients. I assumed, based on your appearance, that you were experiencing homelessness. And I thought that cardiac disease would be less likely than respiratory infection. Why would homelessness make cardiac disease less likely? It's just, Stevens fumbled for words. The answer, Elena said, is that it doesn't. In fact, people experiencing homelessness have higher rates of cardiac disease due to stress, poor nutrition, exposure to elements, and limited access to preventive care. My assumption, Dr. Stevens' assumption, was not based on medical evidence. It was based on bias. She clicked to another slide. This one showed mortality statistics. When we miss cardiac events because we don't take patients seriously, people die. Women are already 50% more likely than men to die from heart attacks because their symptoms are dismissed as anxiety. Black and Latino patients face similar disparities. When you add perceived poverty or homelessness to that equation, the mortality risk becomes catastrophic. Board member Lisa Rodriguez spoke up. What you're describing is horrifying. But I want to understand. You said this is systemic. How do we know this isn't just a few individuals who need more training? Elena had anticipated this question. She clicked to a new slide showing organizational charts and policies. Our current triage protocols include a complexity assessment that's supposed to help prioritize patients. In practice, this assessment is heavily influenced by a patient's perceived ability to advocate for themselves, their appearance, and unconscious assumptions about who really needs care. She pulled up another document. Our patient satisfaction surveys are only given to patients who complete treatment. Patients who leave because they feel dismissed aren't counted. This creates a statistical bias that makes our care look better than it actually is. Furthermore, Elena continued, our physician evaluation metrics prioritize speed and throughput. Doctors are rewarded for seeing more patients in less time. This creates pressure to make quick judgments, and those quick judgments are inevitably influenced by bias. Patricia Hamilton leaned forward. Elena, what are you proposing? Elena clicked to her final section, required interventions. First, immediate implementation of mandatory bias training for all clinical and non-clinical staff. Not online modules people click through. Actual training with simulations, scenarios, and accountability. Second, revised triage protocols that remove subjective complexity assessments and focus purely on medical symptoms. If someone says chest pain, they get cardiac assessment. Period. Third, independent patient advocates in the ER specifically tasked with identifying and intervening in cases where care may be compromised by bias. Fourth, transparent reporting. We publish our wait times, diagnostic testing rates, and patient satisfaction data broken down by demographic categories. Full transparency. Fifth, restitution for the 15 patients who filed complaints and were dismissed. Financial compensation, formal apologies, and offers of follow-up care at no cost. James Park, the legal counsel, cleared his throat. Dr. Martinez, You understand that implementing these measures and publicly acknowledging failures could expose the hospital to significant liability. We're already exposed to significant liability. 15 documented complaints. A board member's first-hand experience. Video evidence. The question isn't whether we're liable, it's whether we're going to do the right thing. Jennifer Morrison raised her hand tentatively. Dr. Martinez. I want to say something. Elena nodded. I didn't know you were on the board. I thought you were just. She stopped herself. I made assumptions. I see that now. And I'm so sorry. Jennifer, tell me why you made those assumptions. Because I've learned to be suspicious. We get drug-seeking patients sometimes. We get people who aren't really in crisis. And I thought I could tell just by looking who needed real care and who didn't. And what did you learn last night? Jennifer's eyes filled with tears. That I can't tell just by looking. That I've probably hurt people who really needed help. That I've been wrong. Elena's expression softened slightly. That awareness is the first step. But awareness without change is just guilt. What are you going to do differently? I'm going to treat every patient like they are you. Like they are someone important who deserves respect and thorough care. Every patient is someone important, Elena corrected gently. Not because they might secretly be a board member or a CEO or someone with power. Because they are human beings in need of medical care. That should be enough. Sarah Chen, the medical student, had been silent until now. She raised her hand. Yes, Sarah. I want to say, I saw what was happening. I knew it was wrong. But I didn't speak up because I'm just a student, and I didn't think anyone would listen to me. Did you speak up today? I sent an email to the medical education director this morning, describing what I witnessed. I said if we're teaching students that this is acceptable care, we're training the next generation to perpetuate discrimination. And what happened? She thanked me for bringing it to her attention. She said she's going to review training protocols. Elena smiled. Sarah, you used your voice. You documented what you saw. You reported it to someone with authority to make changes. That's exactly what witnessing requires. Not having the power to fix everything, just refusing to stay silent. She turned back to the full board. This is how systems change. One person documents discrimination. Others recognize it. Institutions acknowledge it. And then we implement structures to prevent it. Patricia Hamilton looked around the table. I think we need to vote on Dr. Martinez's proposals. All in favor of implementing the 5 interventions she described. 12 hands went up. Unanimous. Motion passes. Martin, I want implementation beginning immediately. Timeline for each intervention. Martin Reeves consulted with his tablet. Bias training can begin within 2 weeks if we bring in external consultants. Triage protocol revisions can be drafted this week and implemented within 30 days. Patient advocates can be hired within 60 days. Transparent reporting can go live within 90 days. And restitution, he looked at James Park. We can begin outreach to affected patients immediately, James said. Settlements can be executed within 90 days. Good. Patricia turned to Elena. What about the public announcement? I'll draft a statement tonight. We should release it tomorrow through all our communications channels. Website, social media, press release to local media. Approved. Patricia stood. Dr. Martinez, thank you for your courage. Thank you for caring enough about our patients to put yourself through that experience. Thank you for listening. And for acting. The statement went live at 9 a.m. the next morning. St. Catherine's Medical Center acknowledges systemic bias in emergency care. Board members' undercover assessment reveals significant disparities in treatment of vulnerable patients. St. Catherine's Medical Center today acknowledges systemic failures in providing equitable care to all patients seeking emergency services. Following an assessment conducted by board member Dr. Elena Martinez, who experienced firsthand the discriminatory treatment documented in multiple patient complaints, our institution is implementing comprehensive reforms to ensure dignity and quality care for every patient. The assessment revealed Significantly longer wait times for patients perceived as homeless or indigent, inadequate diagnostic assessment based on patient appearance, dismissive treatment of legitimate medical concern, security presence used to intimidate rather than protect. We acknowledge these failures. We apologize to every patient who has experienced discriminatory care at St. Catherine's, and we commit to the following immediate actions. Detailed list of 5 interventions. We recognize that acknowledgement without action is meaningless. We will publish quarterly progress reports. The response was immediate. Within 2 hours, the statement had been shared 847 times on social media. Local news picked it up by noon. By 3 p.m., it was trending on Twitter with #HealthcareForAll and #STC accountability. But the real impact came from the patients. Elena's office phone rang at 10 a.m. Her assistant answered, then transferred the call. Dr. Martinez, this is Marcus Thompson. I was one of the patients who filed a complaint 6 months ago. Elena pulled up the complaint file. Marcus Thompson, age 38, presented with back pain after a fall. Minimal examination, discharged with instructions to take ibuprofen. 2 weeks later, admitted to a different hospital with a compression fracture requiring surgery. Mr. Thompson, thank you for calling. I saw your statement. I wanted you to know that when I filed that complaint, nobody believed me. The hospital investigators talked to me like I was lying or exaggerating. They made me feel like I was being difficult for complaining. I believe you, Mr. Thompson. I experienced almost the identical situation. I know. I saw the video. His voice broke slightly. I've been telling people for months that the ER treated me like I didn't matter. Seeing you, someone important, go through the same thing and actually be believed, it means everything. Your complaint is why I did the assessment. You spoke up. That mattered. What happens now? Elena explained the restitution process, the reforms being implemented, the accountability measures. And Mr. Thompson, I want to be clear about something. You didn't need me to validate your experience for it to be real. You deserved proper care the first time. I'm sorry our system failed you. After Marcus hung up, similar calls came throughout the day. Some from patients grateful for validation. Some from family members whose loved ones had been dismissed and later suffered serious complications. Some from healthcare workers at other hospitals saying, this happens here too. At 2 p.m., Elena received a call from Dr. James Rodriguez, the physician who'd treated Marcus Thompson at the other hospital. Dr. Martinez, I'm calling because I've had 5 patients in the past year who came to us after being dismissed from St. Catherine's ER. All had serious conditions, fractures, infections, one with an undiagnosed heart attack. All had been told their symptoms weren't serious. All appeared to be experiencing homelessness or poverty. Are you willing to document these cases? Absolutely. Because I'm seeing the same patterns at my hospital. I just didn't realize how systemic it was until I saw your assessment. By end of day, Elena had received contact from 7 other hospitals in the region. All reported similar patterns. All wanted to know how to implement the same reforms. The next morning, Elena met with the external consulting firm that would lead the bias training. The lead consultant, Dr. Keisha Williams, specialized in healthcare equity. Dr. Martinez, I want to be clear about something, Keisha said. Training alone won't fix this. You need structural changes, accountability mechanisms, ongoing assessment. I know. That's why we're implementing all 5 interventions simultaneously. Good. Because I've seen too many hospitals do diversity training as a checkbox exercise without actually changing anything. Your approach, full transparency, independent oversight, restitution, that's what real accountability looks like. They spent 3 hours designing the training program. It would include simulation scenarios with actors portraying patients' video analysis of real interactions, with patient consent, small group discussions facilitated by equity expert self-assessment of implicit biases, accountability partners to check each other's assumptions, quarterly refresher sessions, integration into all new employee orientation. When can we start? Elena asked. First cohort in 10 days. We'll prioritize ER staff, then expand to all clinical areas. At 4 p.m., Elena received an unexpected visitor. Marcus Williams, the security guard from her ER visit, appeared at her office door. Dr. Martinez, I'm Marcus Williams. I was working security the night you came to the ER. Elena gestured to a chair. I remember you, Marcus. I wanted to. He stopped, struggling with words. I wanted to apologize. I was watching you like you were a threat, making you uncomfortable. That was wrong. Why did you do it? Because that's what I've been trained to do. Not officially. I mean, nobody ever said treat homeless people like criminals. But that's the message I got. Watch certain people more carefully. Position yourself near them as a deterrent. Make them know you're watching. And now I'm seeing it differently. You weren't a threat. That man who fell wasn't a threat. We were treating people who needed medical care like they were problems to manage. What are you going to do about it? I talked to my supervisor. I said I wanted to be part of the training. I want to learn how to help people feel safe instead of surveilled. And I want to speak up when I see other guards doing what I did. Elena extended her hand. Thank you for your courage, Marcus. After he left, Sarah Chen appeared. The medical student looked nervous but determined. Dr. Martinez, I spoke with the medical education director like you suggested. She wants to revise our entire curriculum around equity and bias. She asked if I'd be willing to help design the training for students. What did you say? I said yes. But I wanted to ask you, how do I do this? I'm just a third-year student. I don't have authority or expertise in equity training. Elena smiled. Sarah, you have something more valuable than authority. You have fresh eyes. You see the biases we've become numb to. You have the moral clarity that hasn't been ground down by years of system pressure. Use that. Will they listen to me? Some will. Some won't. But you keep speaking anyway. That's how systems change. Persistent voices refusing to accept the status quo. The reforms rolled out over the following weeks. Week 1. New triage protocols implemented. Every patient presenting with chest pain, shortness of breath, or fall injury received standardized assessment regardless of appearance. Wait times for these cases dropped to under 30 minutes. Week 2. First cohort completed bias training. Feedback was mixed. Some staff embraced it. Some were defensive. Some claimed they already knew this stuff while simultaneously demonstrating blind spots. Week 3. Independent patient advocates began working in the ER. Their presence immediately changed the dynamic. Staff became more conscious of their interactions, knowing someone was specifically watching for equity issues. Week 4. First transparency report published online. The data showed significant disparities in historical treatment. But it also showed dramatic improvements since the reforms began. Month 2. Restitution process completed. 15 patients received financial compensation, formal apologies, and offers of follow-up care. 12 accepted. 3 had moved and couldn't be located. Month 3. Regional Healthcare Equity Summit held at St. Catherine's. 18 hospitals sent representatives to learn about the reform implementation. Elena presented alongside Marcus Thompson, Sarah Chen, Jennifer Morrison, and Dr. Anjali Patel, showing the full spectrum of perspectives. Month 6. Follow-up assessment showed. Wait times equalized across patient demographics, diagnostic testing rates equalized patient satisfaction, scores increased 43%, zero complaints about discriminatory care, staff reporting increased confidence in providing equitable care. But the most significant moment came at a staff meeting in month 4. Dr. Michael Stevens stood before his ER colleagues. The young resident who had dismissed Elena's symptoms looked different, humbled, thoughtful. I want to share something, he began. 4 months ago, I provided inadequate care to a patient because I made assumptions based on her appearance. That patient was Dr. Martinez. But the point isn't that I failed to recognize someone important. It's that I failed to provide the standard of care every patient deserves. He pulled up a slide showing the cardiac workup protocol. I've been reviewing my past cases. In the 6 months before the reforms, I ordered cardiac workups for 83% of white patients presenting with chest pain, but only 41% of Black or Latino patients, and only 12% of patients who appeared to be experiencing homelessness. The statistics hung in the air. I didn't consciously decide to discriminate. I thought I was being efficient. I thought I could tell by looking at someone what they really needed. I was wrong, and my biases could have killed someone. He clicked to the next slide, showing his more recent statistics. In the past 4 months, I've ordered appropriate workups for 94% of all chest pain patients regardless of demographics. Not because I'm watching my numbers, because I've changed how I think about patients. And 3 of those workups identified serious cardiac issues in patients I would have previously dismissed. Dr. Stevens looked directly at the camera, recording the meeting for training purposes. To any medical students or residents watching this, your biases will kill patients if you don't actively work to recognize and counteract them. Nobody is immune to bias. The question is whether you're going to acknowledge it and change, or maintain the systems that perpetuate harm. The meeting ended in standing ovation, not for Stevens personally, but for the courage to speak honestly about failure and growth. 6 months after Elena's assessment, she received an invitation to speak at the American Medical Association's annual conference. The session title, From Compliance to Culture Change, One Hospital's Journey from Discrimination to Equity. The ballroom held over 800 physicians, hospital administrators, and healthcare advocates. Elena stood at the podium, looking out at faces representing institutions across the country. "I'm going to begin with a question," she said. "How many of you have received complaints about discriminatory care at your institutions?" Nearly half the hands in the room went up. Keep your hands up if your institution investigated and found no systemic issues. Most hands remained up. And keep your hands up if, deep down, you suspected there probably were systemic issues, but it was easier to frame complaints as isolated incidents or misunderstandings. About half the remaining hands stayed up. Some people looked uncomfortable. "Welcome to the club. 6 months ago, I was exactly where you are. I'd reviewed complaints. I'd assured board members we didn't have that kind of problem at our hospital. I'd believed our good intentions were enough." She clicked to a photo of herself in the torn jacket, waiting in the ER. "Then I spent 4.5 hours experiencing the discrimination firsthand. And I realized good intentions mean nothing if your systems perpetuate harm." Over the next hour, Elena walked through the assessment, the findings, the reforms, and the outcomes. She showed data proving that equitable care wasn't just morally right, it was medically superior. Patients who felt respected were more likely to follow up with care, more likely to be honest about symptoms, more likely to trust medical advice. She showed financial data proving that preventing discrimination was cost-effective. When patients received appropriate care the first time, they didn't return repeatedly with worsening conditions. When patients trusted the system, they sought preventive care rather than waiting for emergencies. During Q&A, a physician from Texas raised his hand. "Dr. Martinez, I appreciate your presentation, but I'm concerned about the legal implications of publicly acknowledging discrimination. Doesn't that expose your hospital to significant liability?" Elena nodded. "Yes. We've settled several lawsuits stemming from the complaints. We've paid restitution. We've invested significantly in training and structural changes. The financial cost has been substantial. So why do it? Because the alternative, continuing to provide discriminatory care, has much higher costs. Costs in human suffering, costs in mortality, costs in community trust, and eventually, costs in lawsuits we can't defend because we knew about the problem and didn't act." Another hand went up. A hospital administrator from Oregon. "How do you respond to staff who say the bias training is divisive or makes them feel attacked?" "By being clear about the purpose," Elena replied. "This isn't about making anyone feel bad. It's about recognizing that we all have biases, myself included, and those biases affect our medical judgment. The training gives us tools to recognize and counteract those biases so we can provide better care." "And if staff refuse to participate?" then they are not fit to provide patient care at our institution. We've made this non-negotiable. Just like hand-washing and infection control protocols. You don't get to opt out of patient safety requirements. A medical student raised her hand, young, wearing the short white coat that marked her junior status. Dr. Martinez, I'm a first-year student. What can I do if I see discrimination but I don't have any power to change it? Elena smiled. I'm going to introduce you to someone. She gestured to the side of the stage. Sarah Chen, the medical student from St. Catherine's, walked out. This is Sarah Chen. She was a third-year student when she witnessed my experience in the ER. Sarah, tell them what you did. Sarah approached the microphone, visibly nervous but determined. I documented what I saw. I spoke up to the medical education director. I asked if I could help revise curriculum. And when I felt powerless, I reminded myself that being silent was also a choice, one that perpetuated the system. Where are you now in your training? Elena asked. I'm in my 4th year. I'll be starting residency in emergency medicine in July. And I've made it my mission to help create the kind of ER culture where every patient is seen, heard, and treated with dignity. The medical student who'd asked the question nodded, scribbling notes. After the presentation, dozens of people approached Elena with questions, stories, and requests for guidance. Several hospital systems wanted to implement similar assessment protocols. Multiple medical schools wanted to revise their curricula. 3 states' medical boards wanted to discuss mandatory equity training for licensure. But the most meaningful conversation came from an older black physician who approached as the crowd was thinning. Dr. Martinez, I've been practicing for 35 years. I can't tell you how many times I've experienced what you documented, being treated as less than because of how I look. And I've watched it happen to patients for decades. Thank you for making it visible. I wish I'd done it sooner. You did it when you could. That matters. That evening, Elena received a call from the Department of Health and Human Services. The caller introduced herself as Deputy Director Chen, no relation to Sarah or any of the other Chens in this story, though Elena was beginning to think the universe was being ironic with the naming patterns. Dr. Martinez, we've been reviewing your hospital's reforms. We'd like to develop them into a model program that could be implemented nationwide. Would St. Catherine's be willing to participate in a federal pilot program? What would that entail? Technical assistance to other hospitals implementing similar reforms. Research collaboration to document outcomes. Potential federal funding to support wider implementation. I'll need to discuss with my board, but I believe they'd be supportive. On one condition. What's that? The pilot program includes community oversight. We don't need more top-down reforms designed without input from the people actually experiencing discrimination. Agreed. We'll establish community advisory boards at each pilot site. After the call ended, Elena sat in her hotel room, processing the day's events. Her impromptu assessment 6 months ago, born from frustration with a system that wouldn't acknowledge its failures, had become a national model. But she also thought about all the patients she hadn't been able to help. All the people who'd experienced discrimination before the reforms. All the health conditions that had been missed, minimized, or dismissed because bias had distorted medical judgment. Change was happening, but it couldn't undo the past harm. Her phone buzzed with a text from Marcus Thompson, the patient who'd filed the complaint that started everything. Just saw you were on the news. National news. Thank you for not giving up on this. Elena responded, thank you for speaking up. Change started with your courage. 1 year after Elena's assessment, St. Catherine's Medical Center looked fundamentally different. The ER waiting room had been redesigned with input from community members and patient advocates. Comfortable seating replaced plastic chairs. Large windows brought in natural light. A resource wall provided information about housing assistance, mental health services, addiction recovery programs, and patient rights, with materials in multiple languages. Most significantly, a patient dignity charter hung prominently near the entrance. At St. Catherine's Medical Center, we believe, every person deserves respectful care regardless of appearance, housing status, or financial resources medical assessment must be based on symptoms and evidence, never on assumptions or bias. Patients are experts on their own bodies and experiences. Healthcare is a human right, not a privilege. We are accountable to the communities we serve. The charter was signed by every staff member. It was referenced in training. It was the measuring stick against which all policies were evaluated. Elena stood in the ER lobby on the anniversary of her assessment, watching the morning shift change. Dr. Anjali Patel, who'd been so shaken by her own recognition of bias a year ago, now led the hospital's equity committee. Jennifer Morrison, the triage nurse who dismissed Elena, had become a vocal advocate for standardized assessment protocols. Dr. Michael Stevens had just been promoted to chief resident and had made healthcare equity his research focus. His latest paper, How Implicit Bias Affects Diagnostic Accuracy in Emergency Settings, was being published in JAMA. Marcus Williams, the security guard, now trained all new security staff on dignity-centered security practices. The emphasis had shifted from surveillance to support. And Sarah Chen had matched into emergency medicine residency at St. Catherine's, specifically choosing it because of the culture change she'd witnessed. But the most important change wasn't visible in policies or protocols. It was visible in moments. Elena watched an elderly man approach triage. His clothes were worn, his appearance disheveled. The triage nurse, a new hire named James Rodriguez, greeted him with genuine warmth. "Good morning, sir. How can I help you today? I've got this pain in my chest. Comes and goes. Okay, let's get you checked out. Can you describe the pain for me? Is it sharp, dull, pressure?" James didn't reach for hand sanitizer. Didn't make assumptions. Didn't dismiss. He asked thorough questions, listened carefully to the answers, and entered the patient into the system for immediate cardiac assessment. 20 minutes later, the man was in a treatment room having an EKG. 30 minutes after that, Dr. Stevens was explaining that the EKG showed concerning changes and they'd need to do further testing. "You may have saved his life," Dr. Patel said to James later. "That could have been a heart attack in progress." "Just doing what I was trained to do," James replied. "Treat every patient like they matter." Elena smiled. That was the culture shift, when treating patients with dignity moved from policy aspiration to automatic practice. Her phone rang. Patricia Hamilton, the board chair. "Elena, I wanted to give you an update on our quarterly metrics." "Good news or bad?" "Extraordinary news. Our patient satisfaction scores are the highest in the region. Our clinical outcomes have improved across all demographic categories. And we've had 0 discrimination complaints in 6 months. That's wonderful. But Patricia, we need to stay vigilant. Systems don't stay changed without constant attention." "Agreed. Which is why the board voted this morning to make the Equity Committee permanent and to expand its authority. We want quarterly public reporting indefinitely." "That's excellent. There's more. The federal pilot program has been so successful that HHS is mandating similar protocols for all hospitals receiving Medicare funding. Your assessment is becoming national policy." Elena let that sink in. One undercover visit. One documented experience. One institution's willingness to acknowledge failure and commit to change. And now hundreds of hospitals would be required to implement similar reforms. "Elena, you still there?" "I'm here. Just processing. A year ago, I sat in this ER for 4.5 hours being dismissed and surveilled. Now the experience has literally changed federal policy. Because you refused to stay silent. Because you documented everything. Because you focused on systemic change instead of individual punishment." After the call ended, Elena walked through the hospital, observing. In the cafeteria, Marcus Williams sat with a group of new security staff, teaching them de-escalation techniques and dignity-centered practices. "Your job isn't to make people feel threatened," he explained. "It's to help people feel safe." In a conference room, Sarah Chen led a discussion with medical students about recognizing bias in clinical reasoning. "The question isn't whether you have biases," she said. "Everyone does. The question is whether you're going to let those biases affect patient care." In the ER, Jennifer Morrison was precepting a new triage nurse. When someone says they are in pain, we believe them. When someone says they need help, we help them. Every patient. Every time. Elena found Dr. Stevens reviewing charts in the physician workroom. Dr. Stevens, can I ask you something? Of course, Dr. Martinez. How do you think about what happened a year ago? Do you carry guilt about it? Stevens was quiet for a moment. I carry responsibility. There's a difference. Guilt is paralyzing. It's about me and my feelings. Responsibility is active. It's about making sure I never make those mistakes again and helping other people avoid them. That's a mature perspective. I learned it from you. You didn't destroy my career when you could have. You gave me a chance to be better. I'm trying to earn that chance every day. That evening, Elena returned to her office at Memorial Hospital. Her assistant had left a stack of messages, interview requests, speaking invitations, hospitals seeking consultation. But one message stood out. An email from a woman named Diana Reeves. Dr. Martinez, you don't know me, but I was the patient in the St. Catherine's ER the night you were there. I came in with a sprained ankle, the teenage girl. I watched everything that happened. I recorded some of it on my phone. At the time, I was just watching drama unfold. I didn't think about what it meant. Now I'm in my first year of college. I'm studying to be a physician assistant. And I keep thinking about that night. About how different patients were treated differently. About how you stayed calm even when you were being disrespected. About how you used what happened to change the whole system. I want you to know that you changed my path. I chose healthcare because of what I witnessed. And I'm going to spend my career making sure every patient gets treated the way you should have been treated from the beginning. Thank you for showing me what real healthcare advocacy looks like. Elena read the email 3 times. This was the real impact, not just policy changes or federal mandates, but individuals inspired to be better, to do better. She began typing a response. Diana, thank you for reaching out. Your decision to pursue healthcare with awareness of these issues is exactly the kind of change we need. The system doesn't change through policies alone. It changes through people like you who refuse to accept discrimination as normal. I'd like to invite you to shadow in our ER when your schedule permits. Come see how we've implemented the changes. Ask questions. Challenge us. Help us get better. And Diana, you witnessed what happened, and you're using that witness to fuel positive change. That's powerful. Never underestimate your ability to make a difference. After sending the email, Elena pulled up the original video from her assessment. She'd watched it dozens of times in the past year, always finding new details to analyze, new moments that revealed how bias operates. But tonight, she watched it differently. Not looking for what went wrong, but seeing what was now different. The dismissive triage assessment that would now trigger immediate review and retraining. The 3-hour wait that would now be flagged by the equity monitoring system. The cursory examination that would now fail the standard care protocols. The surveillance that would now be recognized as dignity violation and addressed. Every failure point in her experience had been identified, analyzed, and restructured. The system wasn't perfect. Systems never were. But it was profoundly better. Her phone rang. An unfamiliar number. Dr. Martinez. This is Marcus Thompson. I hope it's okay to call. Of course, Marcus. How are you? I'm good. Really good, actually. I wanted to tell you, I went back to school. I'm studying to become a patient advocate. I want to help other people navigate the healthcare system and make sure they get treated right. Elena felt emotion tighten her throat. Marcus, that's wonderful. It's because of you. Because you showed me that the system could change. That my experience mattered. That someone would actually listen. Your experience always mattered. I'm just sorry it took so long for the system to acknowledge it. But it did acknowledge it. That's the point. A year ago, I thought I was crazy for complaining. Now there are whole new systems in place to prevent what happened to me. That's incredible. After the call ended, Elena sat in the quiet of her office, reflecting on the journey. 1 year ago, she'd put on borrowed clothes and walked into an ER as a patient. She'd endured dismissal, surveillance, and inadequate care. She'd documented everything. And then she'd done the hardest part. She'd made it public. She'd acknowledged systemic failure. She'd pushed for transparency and accountability even when it was uncomfortable, expensive, and risky. The transformation hadn't been easy. Staff resistance, legal complications, media scrutiny, financial costs, difficult conversations. But the alternative, allowing discrimination to continue unchallenged, was unacceptable. Elena opened her laptop and began drafting her next presentation. She'd been invited to speak at the World Health Organization's conference on health equity. The title of her talk, From Witnessing to Action, How One Experience Can Transform Healthcare Systems. She wrote, "Change begins with someone willing to make invisible discrimination visible. It continues with institutions willing to acknowledge failure. And it succeeds when we build accountability into the structures that guide daily practice." 1 year ago, I experienced healthcare discrimination firsthand. Today, that experience has contributed to federal policy changes affecting every hospital in America. But the real transformation isn't in policy documents. It's in the daily practice of treating every patient with dignity. This is what I learned. Systems don't change through good intentions. They change through documentation, accountability, transparency, and persistent voices refusing to accept discrimination as normal. If you're witnessing discrimination in healthcare, document it. Report it. Demand change. Your voice matters. Your experience matters. And the system can change if enough of us insist that it must. 2 years after Elena's assessment, the National Healthcare Equity Initiative held its first annual conference. Over 2,000 attendees filled the convention center. Physicians, nurses, administrators, patient advocates, community organizers, and policymakers. The opening keynote featured a panel, Dr. Elena Martinez, Marcus Thompson, now a certified patient advocate, Sarah Chen, completing her emergency medicine residency, and Diana Reeves, in her 3rd year of physician assistant school. The moderator asked, "How do we sustain this momentum? How do we ensure healthcare equity isn't just a moment, but a movement?" Elena answered first, by making equity measurable and visible, by publishing data, by creating accountability structures that persist beyond any individual's attention span, by building community oversight into every level of healthcare governance. Marcus added, by centering the voices of people who've experienced discrimination. Stop treating us like we're the problem to be managed. Treat us like we're the experts on our own experiences. Include us in designing solutions. Sarah said, by training the next generation differently. Medical education has to explicitly address how bias affects clinical reasoning. We have to practice recognizing and counteracting our assumptions before we're making life and death decisions. Diana concluded, by remembering that every policy, every protocol, every reform exists to serve human beings. When we lose sight of the people behind the numbers, we lose our way. Keep the stories centered. The conference showcased the ripple effects of St. Catherine's reforms. 340 hospitals had implemented similar assessment protocols. 12 states had mandated equity training for healthcare licensure. Federal policy now required discrimination monitoring and public reporting. Patient advocacy programs had expanded dramatically. Medical school curricula had been revised. Nationwide community oversight boards were standard practice. But the most powerful moment came during a workshop called From Patients to Partners. 15 individuals who'd filed discrimination complaints at various hospitals over the past decade stood before the audience. They shared their stories, the dismissals, the harm, the long-term health impacts of not being believed. Then they shared what happened after, the apologies, the restitution, the policy changes, the invitation to serve on hospital equity committees. One woman, Maria Santos, spoke about experiencing a heart attack that was initially dismissed as anxiety because she was Latina and didn't fit the doctor's image of a cardiac patient. "I almost died because someone made assumptions," she said. "But now I sit on the cardiac care committee at that same hospital. I review protocols. I train staff. I make sure what happened to me doesn't happen to anyone else. Another speaker, James Wilson, described being denied adequate pain management during a medical emergency because the staff assumed he was drug-seeking. The physical pain was bad, he said. The indignity was worse. But the hospital that hurt me is now leading the region in equitable pain management practices. They brought me in to help develop the protocols. They listen to me now. The message was clear. Accountability doesn't mean destruction. It means transformation. It means bringing those who were harmed into the process of healing the system. During a break, Elena found herself surrounded by medical students asking for advice. How do we challenge bias when we're at the bottom of the hierarchy? One asked. By documenting what you see. By speaking up anyway, even when it feels risky. By remembering that silence is complicity, Elena replied. But what if we face retaliation? You might. I can't promise that standing up for what's right is risk-free. But I can promise that staying silent has costs too. Costs paid by patients who depend on you to advocate for them. A student in the back raised her hand. Dr. Martinez, did you ever imagine that one ER visit would change federal policy? Elena smiled. No. I just imagined documenting what was happening so it couldn't be dismissed as isolated incidents anymore. I imagined making discrimination visible. Everything that followed came from people seeing that documentation and demanding change. So we can make a difference too. You already are. By choosing healthcare with awareness of these issues. By committing to practice equity, not just preach it. By refusing to accept discrimination as normal. That's how movements build. The conference ended with a call to action. Healthcare professionals, complete bias training. Examine your own practices. Speak up when you witness discrimination. Support patients who file complaints. Hospital administrators, implement transparent reporting. Create accountability structures. Center community voices. Make equity a core institutional value, not a PR statement. Patients, document your experiences. File complaints when care is inadequate. Demand dignity. Know your rights. Everyone, recognize that healthcare discrimination contributes to preventable death and suffering. This isn't abstract, it's literal life and death. Demand better. 3 years after Elena's assessment, she received an invitation to return to St. Catherine's for a special event, the opening of the Elena Martinez Healthcare Equity Center. She'd initially protested the naming. This isn't about me, she'd told Patricia Hamilton. It's not, Patricia had replied. It's about what you started. The center will provide training, research, and advocacy to continue the work. Your name reminds us why it matters. The center occupied the renovated ground floor of St. Catherine's. Its walls displayed patient stories, with permission, documenting experiences of discrimination and recovery. Its staff included patient advocates, equity consultants, and community organizers. Its mission, ensuring no one would experience what Elena experienced. During the opening ceremony, Marcus Thompson cut the ribbon. The former patient who'd filed a complaint now stood as a symbol of transformation. 3 years ago, I was dismissed and hurt by this hospital, he said. Today, I work here as a patient advocate. That's what accountability looks like. That's what real change looks like. Elena spoke last. When I walked into this ER 3 years ago, I expected to find evidence of discrimination. I found it. But I also found people who were willing to change. People who were willing to acknowledge failure and commit to doing better. This center exists because of everyone who chose courage over comfort. The patients who spoke up. The staff who admitted their biases. The institution that chose transparency over reputation management. The community that demanded accountability. Healthcare discrimination doesn't end because of one assessment or one hospital or one policy change. It ends through sustained commitment to equity. Through constant vigilance, through refusing to accept good enough when we can do better. This center is a beginning, not an ending. The work continues. The audience included representatives from the 340 hospitals that had implemented similar reforms, medical students from 12 universities, policymakers from 18 states, patient advocates from dozens of organizations. And in the front row sat Jennifer Morrison, Dr. Michael Stevens, Dr. Anjali Patel, Marcus Williams the security guard, Sarah Chen, and Diana Reeves, the web of people whose lives had intersected that night and who'd all chosen transformation over stagnation. After the ceremony, Elena stood in the center's main room, looking at a wall of impact statistics. Healthcare discrimination complaints down 73%, national cardiac outcomes improved 31% in populations previously experiencing disparities, patient trust in healthcare systems up 41%, medical students reporting confidence in recognizing and addressing bias, 84%. But her eyes kept returning to one display, patient testimonials. For the first time, I felt like my pain was taken seriously. They believed me when I said something was wrong. I didn't feel judged. I felt cared for. They saw me as a human being, not a stereotype. That was the real victory. Not the policies or the federal mandates or the center with her name on it. The victory was in those moments when patients felt seen, heard, and valued. Elena's phone buzzed. A text from an unknown number. Dr. Martinez, you don't know me, but I'm an ER patient at St. Catherine's right now. I just wanted to say thank you. The nurse took extra time to listen to my concerns. The doctor explained everything carefully. Everyone treated me with respect. I read the story about what you did, and I wanted you to know, it worked. The system is different. Thank you for making it different. Elena showed the text to Marcus Thompson. That's why we did this, he said quietly. So that person would get the care I didn't get. So the system would work for them the way it should have worked for me. Are you glad you filed that original complaint? Elena asked. Yes, because someone listened. Because it mattered. Because change happened. Marcus paused. A lot of people told me not to complain. Said it wouldn't make a difference. Said I should just accept how things were. I'm glad I didn't listen. As the reception continued, Elena found a quiet corner. She pulled out her phone and opened a document she'd been drafting, a guide for patients and advocates called How to Document and Challenge Healthcare Discrimination. The guide included what to document, conversations, wait times, treatment decisions, how to file effective complaints, what rights patients have, where to find support, how to escalate concern, success stories to inspire action. She added one final section. To anyone experiencing discrimination in healthcare, your experience is real. Your concerns are valid. Your dignity matters. Document everything. Speak up. File complaints. Demand accountability. The system can change. I've seen it change. But it changes because people like you refuse to accept discrimination as normal. You deserve quality care. You deserve respect. You deserve to be seen, heard, and valued. Don't stay silent. Your voice matters. Elena saved the document and sent it to the National Patient Advocacy Network for distribution. As the evening concluded and guests departed, Elena stood alone in the center for a moment. She thought about the night 3 years ago when she'd sat in that ER waiting room, watching patterns of discrimination unfold. She thought about the courage it took to make that experience public. She thought about all the people who'd joined the movement for change. And she thought about the patients who would never know that an assessment they never witnessed had changed the care they were receiving. That was fine with her. The point was never recognition. The point was change. Elena turned off the lights and locked the center's doors. Tomorrow, the work would continue. It would always continue. Because healthcare equity isn't a destination you reach. It's a commitment you keep. Every day. Every patient. Every time. If you or someone you know has experienced discrimination in healthcare, document it. Write down dates, times, names, what was said and done. Keep copies of all medical records. Take photos if appropriate and safe to do so. Report it. File formal complaints with the hospital's Patient Relations Department, your state's medical board, and the Federal Office for Civil Rights, HHS.gov/OCR. Seek support. Contact patient advocacy organizations like the Patient Advocate Foundation 1-800-532-5274 or the National Health Law Program. Know your rights. The Emergency Medical Treatment and Labor Act, EMTLA, requires hospitals to provide stabilizing treatment regardless of ability to pay. The Affordable Care Act prohibits discrimination based on race, color, national origin, sex, age, or disability. Tell your story. When you're ready and if you feel safe doing so, sharing your experience helps others recognize discrimination and can build momentum for change. Healthcare discrimination is not inevitable. It's not acceptable, and it can be challenged. Your dignity matters. Your health matters. Your voice matters. Share this story. Subscribe for more stories of justice and transformation. And if you witness discrimination, speak up. Document it. Demand change. Because the system only changes when we refuse to accept that it's unchangeable. While Dr. Elena Martinez and St. Catherine's Medical Center are fictional, the experiences depicted reflect real patterns affecting millions of patients. The reforms described are based on evidence-based interventions that have successfully reduced discrimination in healthcare settings. Change is possible. It requires acknowledgement, accountability, and sustained commitment. But it is possible. If this story resonated with you, share it. Subscribe for more stories that challenge injustice and inspire action. And remember, you have the power to demand better. Use it.